he is having 1, 2, 3, I think. Yes.
Action.
Hello friends, welcome to the next season of Vantage Point, our beloved show on DocFlex. I am Dr. Parth Rana. I am retina and ocular trauma surgeon, and I am a patent owner of true intraocular lenses and few retinal imaging devices. So here we are going to discuss on diabetic retinopathy. Diabetic retinopathy is a major ocular complication of diabetes mellitus and is a problem with significant global health impact. Major advances in diagnosis technology and treatment have already revolutionized how we manage diabetic retinopathy in early part of 21st century. For example, the accessibility of imaging with optical coherence tomography and the development of anti-VEGF treatment are just some of the landmark developments that have shaped the diabetic retinopathy landscape over the last few years. Yet there are still more advances being made, like ultra wide field cameras, OCT-A, and we are going to discuss all these things here. In this discussion, we'll focus on diabetic retinopathy. As an ophthalmologist, I will provide my perspective, and joining with me is our dear friend Dr. Phatak sir. He is an endocrinologist. Welcome to the show, sir. Dr. Sanjeev Phatak, he is a renowned endocrinologist in Gujarat as well as in India. So let's discuss the underlying mechanism of diabetic retinopathy.
Well, Dr. Path, there are multiple mechanisms. One is the advanced glycation pathway, the polyol pathway, and several other mechanisms. But let us not go into the pathophysiology, but what are the important things which cause diabetic retinopathy? The most important is the degree of hyperglycemia or the degree of glycemic control. The second most important thing is the duration of diabetes. Sometimes longer duration of diabetes, even when controlled, can lead to retinopathy. And third is the presence of hypertension in a person with diabetes definitely increases the risk of retinopathy. So these three mechanisms are there. Unfortunately, most of the patients miss the early diagnosis, and that's why they'll end up into problems. So in addition to the pathogenetic factors which we already discussed, like the protein kinase C pathway, COX-2 activation, the phospholipase A2 activation, then the advanced glycosylation end products, 𝐏𝐴 pathway, all these pathways to one or other extent play an important role in initiating as well as worsening of the diabetic retinopathy.
So basically there is no clear underlying mechanism. It can be any of them or it can be something else.
Yes,
also.
absolutely.
Yeah, and even though if diabetes is controlled, diabetic retinopathy can progress.
Yes,
so
with long duration of diabetes, and sometimes genetic susceptibility also plays a role.
Yes, because so many times like people have that tendency, if diabetes is controlled, and even though if diabetic retinopathy is progressing, they have the thinking that my diabetes is controlled and why it's happening like that. So we have to clear this thing, that even though your diabetic status is controlled, your HbA1c is under control, and even though diabetic retinopathy can progress, because it is a separate disease, it's not just related to diabetes, it's a whole new separate disease which can go even after diabetes is controlled.
Yes, very well said. And in UKPDS, you know that 20% of the people had diabetic retinopathy at the diagnosis of diabetes.
Very true, sir. So because we don't know from how long they have
exactly.
diabetes.
Precisely.
So when it is diagnosed, by that time also diabetic retinopathy can be there, and that's why we always prefer to have a screening of retina at the time of diagnosis
yes,
of
in type
diabetes.
2, absolutely, yes.
Yes, and even type 1 also sometimes when it is a delayed diagnosis.
Correct.
Yeah.
So type 1 general recommendations are at 5 years to start with, and in type 2 right from the diagnosis every year.
Very true, because it will tell you from how long the diabetes is there.
Absolutely, because the microvascular complications sometimes start even before the clinical onset of diabetes, both micro and macro.
Yes, true, sir. So can we throw some light on glycemic control on progression of diabetic retinopathy?
Yes, it is very important. You know that the microvascular complications are very much impacted with the degree of glycemic control, not the macrovascular or the cardiovascular. But retinopathy in particular is definitely related to the degree of glycemic control. Better the control, less will be the risk of retinopathy, and that was proven in the not only UK PDS but some other trials also. Less than 7 HbA1c is associated with much less risk of diabetic retinopathy, but having said that, we discussed that the duration of diabetes and sometimes the genetic factors also influence. But if you control diabetes well, as close to 7 as possible, the risk will be definitely less. But in addition to that, these days, not only HbA1c, but we are seeing a good impact of the time in range that is derived from the CGMS data, that more the person spends in the range, less is the risk of diabetic retinopathy. So, the degree of HbA1c control and time in range both determine the risk of retinopathy.
So, it's very well said, sir. And as you mentioned CGMS, so is it necessary for all the cases to do CGMS in all the cases?
May not be absolutely necessary for everyone, but those patients who are on insulin, maybe single dose or multiple dose, all type 1 diabetic patients, and those patients with glycemic variability, patients on sulfonylurea where you expect hypoglycemia or hyperglycemia, these are the candidates who should be doing regular CGMS. For a person who is just on a DPP-4 inhibitor plus metformin or SGLT2 plus metformin, not at risk of hypoglycemia or severe hyperglycemia, may not need it necessarily.
If a patient is having diabetic retinopathy for a longer period and if it's not getting controlled, then we should go for CGMS.
Yes, absolutely right, because then you are expecting some hypos and hyper or glycemic variability which we need to look at.
Because like as in my OPD, when I see so many of the cases, when patient is coming to me that he is totally religious on taking medicine daily, and then patient is explaining me he is even checking his RBS and PPBS once in every 10 days or 15 days, and everything is in control. And even though diabetic retinopathy is progressing, so many times it's not necessary that sugar is controlled and then diabetic retinopathy should be controlled with that. But even I have tried in that cases CGM, and then I have seen that some variability is there at time of evening and night when patient is not taking his blood sugars. So I feel it's very important nowadays, and it's a really groundbreaking thing for this diabetic retinopathy cases.
I fully agree with you, absolutely, that CGM has definitely changed the way we practice, because previously we never used to realize that there is so much of variability even in patients with HbA1c of less than 7. So in such cases, definitely CGM should be done so that we can pick up the variability, hypos, hypers, and can modify the treatment or diet accordingly.
And what can be the interval when they should repeat the CGM?
Well, it has to be individualized. For a type 1 diabetic patient, if they can afford, they should be on regular CGM, or at least once in a quarter or once in 6 months. For type 2 diabetes, maybe at least once in a year, so that we know how much the diet or the treatment influences their glycemic variability.
What role, according to you, does inflammation play in pathogenesis of diabetic retinopathy, and are there any therapeutic implications on that?
Yes, a very good question, because these days for most of the diabetic complications, inflammation plays a central role. So in addition to hyperglycemia or duration, there is presence of inflammation which worsens all these things, and the inflammatory markers may not be present there. There are subclinical markers, and these are definitely responsible for initiating as well as worsening of retinopathy, neuropathy, nephropathy, everything. The features of inflammation which include macrophage infiltration, leukostasis, but the hallmarks are new vessel formation, that is angiogenesis, and neurodegeneration.
So same as in ophthalmology, we have different non-invasive retinal imaging available right now, which is fluorescent angiography, autofluorescence imaging, as well as OCTs are available. We call it ocular coherence tomography. So this advancement in this OCTs where we can see retina, even below the retina neurosensory layers, even a choroid also we can see in non-invasively in this OCTs, and there we are seeing so many of the different pathologies what we were not able to see before. So this subfoveal neuroretinal sensory detachment which is there in diabetic macular edema, it is mainly due to the higher IL-6 levels. So when this higher IL-6 levels are there, So we are understanding that in this case we need to give steroids in that, and so many times this fluid, it is having its own autofluorescence. So when we are checking it with the autofluorescence imaging, then we are able to see this whether autofluorescence is there on fovea or not. If autofluorescence is there on fovea, this means that there are higher inflammatory factors available at the macula, and then also we should definitely go for some steroids along with whatever treatment we are giving right now.
Correct. So I think the anti-inflammatory, whether it is topical or ophthalmic or systematic, definitely works for treatment of diabetic retinopathy. I believe you know better.
Yes, definitely, because so many times it is saying, like, whenever, like before, if we see there was a tricot injection, triamcinolone acetonide injection. Correct. Was very common for all these pathologists. But as the time has passed, and as we have newer molecules like anti-VEGF molecules are there in market, so most of us are only going for them. Now we are not going for anti-inflammatories like steroids. We are not using it due to their few side effects.
Correct.
We have stopped using it. But as we can see, as we have this all biomarkers available with us now, so all these biomarkers are saying us that we need to have some anti-inflammatory molecule attached with this anti-VEGFs, so this anti-VEGF can work better in that. So in our routine practice, I have seen most of our books or most of our driven market right now, if we see, all of them are going behind only anti-VEGFs, but the role of steroids is still there, and it is said by all these pathologies what we are seeing in this biomarkers.
So anti-inflammatory things, maybe it is cardiovascular disease or whether it is retinopathy, or even now for nephropathy we have phenylalanine, which also has an anti-inflammatory action.
Yes.
So I think inflammation definitely has a very important role to play in pathogenesis of all these complications.
Very true, sir. So we have discussed the pathogenesis nicely. So can we discuss on non-vascular aspects? So what physicians should know about this non-vascular aspects of this diabetic retinopathy?
Yes, it's a very interesting thing that you have brought. All these years we have believed that diabetic retinopathy is a vascular disease or a microvascular disease. But the current hypothesis and the current research suggests that it is not just about the vessels, it is also about the nerves. So now we term it as a disease of neurodegeneration or diabetic neural or retinal neurodegeneration rather than just vascular thing. So the focus has shifted from vascular to neurovascular or neural maybe, and that may have some implications on the treatment as well.
So actually what we discussed, this diabetic retinal neurodegeneration, it is a really hot topic right now, and it is a really new thing, and with the advancement in OCTs right now we are able to see lot more things which we were able to see before. So if we see for inner retinal layers like ganglion cell layers and retinal nerve fiber layers, this all layers are getting thinned out in starting of the disease, and even before any diabetic retinopathy lesion is seen on the retina, before that also we are able to see thinning of these layers in OCTs. So many of the OCT studies have shown us that before any lesion comes, before we can say that diabetic retinopathy has started, we are able to see thinning of these layers, and it is showing us that this is the starting of the disease, and I think in future this will be the main thing from which we are going to start our treatments. Even these patients, we are seeing some of the functional defects also. So functional defects, as we can see, as a contrast sensitivity is diminishing in this patients, as we are able to see some visual field defects also. Like normally visual field defects we are always correlating with the glaucoma, but here also in some of the patients we are able to see visual field defects here. Some electrophysiological defects also we are able to see here. So many functional defects are also starting due to this diabetic retinal neurodegenerations. So this DRN, it's really a new marker which we say for our treatment again. DRN has some prognostic value for its ocular and systemic outcomes. So in future we'll need some more quantification, and we'll need some proper methods for assessment and quantification of this DRN, and with that we'll be able to prognosticate the quality of life of that patient in future. And if we see for our day-to-day OPDs, in day-to-day OPDs, we can just do the pupillometry. This pupillometry can give us some data on DRN, and this DRN, so many of the researchers are trying to incorporate this DRN with our existing DRN classifications and management protocols. Also, we are trying to incorporate DRN into that, and with simple pupillometry tests also we can incorporate it in our routine practice.
So, what you said would mean that in addition to the routine retinoscopy, you should be doing the OCT also or the pupillometry also, so as to diagnose the diabetic retinopathy, or what you said, DRN, diabetic retinal neurodegeneration.
Yes, perfectly. So as we are seeing mainly, as in all our protocols, if we see most of our protocols, we are just seeing the fundus photos first. As we are seeing fundus photo, if any lesion is there in that, and then only we are going for OCT or autofluorescence or retinal angiography. So after all that thing, we are going for some more reports. But here, according to the new studies, we should go for OCT first. So in OCT, even though we are not able to see any marked lesion on the retina, we are able to see the thinning in inner retinal layers. So this thinning in the inner retinal layers shows us that this patient is going to have a diabetic retinopathy.
Well, Dr. Parth, can you provide some, or you can throw some light on the updated classification of diabetic retinopathy, and in addition, can you tell us, will it have some implications on the treatment of retinopathy?
It is a really good question, sir. If we see, basically all these classifications are made for stratifying the progression and prognostic factors for that. So if we see previously in mid-20th century, if we see, there are ophthalmoscopic classification was there, Hemsworth classification was there. But as time progressed and as we have new modalities for investigations, we are changing our protocols and we are changing our classifications according to that. Recent classification, if we see, it is ETDRS classification is there. It is early treatment diabetic retinopathy study classification is there. In this ETDRS classification, we are taking 7 retinal photos, and with this 7 retinal photos, we are seeing the progression of diabetic retinopathy with that. It is mainly used in clinical research, but it's very complex to use in our day-to-day practice. So for our day-to-day practice, there's one more classification available, which is a simplified version of ETDRS classification. It is an International Clinical Diabetic Retinopathy Severity Scale. Even this ETDRS and ICDR classification, they are also around 2 to 3 decades old. And as I have already mentioned that we are taking 7 retinal photos here in ETDRS classification, and then we are checking the scale of diabetic retinopathy. But this is only getting us to a 30% retina, what we are capturing there. And basically we are leaving all the peripheral retina, and so many times this peripheral retina gives us clues about the prognostication of this retinopathy. So in nowadays, when ultra wide field imaging is easily available in market, so we have to change our classification also according to that. But as a gold standard, if we say for right now, it is ETDRS classification. Even if we see for diabetic macular edema is a leading cause of visual impairment in diabetic retinopathy. But there's no implication of diabetic macular edema on in this ETDRS classification. We are mainly focusing on progression of diabetic retinopathy and progressing it to proliferative diabetic retinopathy. We are just marking that. We are not going for diabetic macular edema. Even we have not incorporated some of the visual functions such as best corrected visual acuity, we call it as a BCVA. We have not even incorporated contrast sensitivity in that. Even visual quality per se, if we see, we have not incorporated in ETDRS classification. So all these visual functions are also very much important to see for classification. Even PROMs, we call it PROMs as a patient reported outcome measures. This PROMs is also very important in measuring the overall outcome of patient's vision. So this all factors are important in patient's vision, but they are not incorporated in right now the gold standard of classification, which we call it as a ETDRS classification. So there are a lot of studies going on newer classifications, and future I think we'll see newer classifications based on ultra wide field imaging, as well as patient's quality of vision, and the different visual functions also will be incorporated in that. And it might not be that much complex as what ETDRS classification it is there right now. So what I feel from my side, the usual classification, what should be there, it will be something like what all we are having in our OPD. According to that instruments, with that instruments, we are able to measure the diabetic retinopathy progression and all the factors from patient side also, patient's quality of life, patient's happiness, that all things should be incorporated in that.
So very well said that like the guidelines, the classifications should also be patient centric.
Yes.
In addition, I would like to ask you, Dr. Parth, that what as an ophthalmologist are you doing your best to screen for the diabetic retinopathy patients? Because having discussed all this, unfortunately, the screening for diabetes retinopathy still remains very low, not only in the rural areas but also in the cities.
Very true, sir. The basic thing, if we discuss for my day-to-day practice, if I'll tell, screening is really difficult for diabetic retinopathy patients, because these patients are not having visual impairment till late stages.
Absolutely.
Because most of the patients, they are having disease in peripheries in starting. So when the patient is having starting of disease in periphery of the retina, he is not having any visual defect in the central field. So patient, when when even doctors in your stage also, when you are asking a patient to go for a checkup at a retina center or an ophthalmologist, they are usually saying, sir, I am able to see everything, why I should go and screen my eyes?
Absolutely.
So most of the time this thing is happening. So screening is a very crucial part, because in early stages there's very less damage on the retina, and we can reverse that damage with some few medications only. We don't have to go for retinal photocoagulation or anti-VEGF injections. We can treat the patients at very early stage, and we have to go to the patient in starting stage. We have to educate the patient, and that can be done by me, that can be done by my technician, that can be done by the practitioner who is seeing the diabetes patient. Everyone has to have some education program for all the patients, and then only we can save the society. Otherwise, India is a capital of diabetes, and diabetic retinopathy also India is capital. So future is really doomed if we don't educate our patients.
Correct. So screening plays a very important role in preventing the advancement as well as for the diagnosis of diabetic retinopathy. You said it very precisely. So to sum up about the screening, we can conclude that type 1 diabetes, if not at diagnosis, at least 5 years from the diagnosis, and then every year.
Yes.
If even if the fundus is normal or the retina is normal. For type 2 diabetes, right at the time of diagnosis, and then annually, even if it is normal. In case there is an early retinopathy, at least biannually, and if patient has progressive diabetic retinopathy, then definitely more frequently, as you rightly said.
Yes, definitely. So it was a great episode, and with this we end the episode on pathogenesis of diabetic retinopathy. More aspect to unfold in the next episode. Thank you.